So we're going to move on now to our final speaker of the evening, Dr. Sumi Britton, who's going to talk to us about syphilis. So Sumi Britton is an infectious diseases physician also at the Mater Hospital in Brisbane, who has an interest in infections in pregnancy and is the chairperson of the Infection in Pregnancy Multidisciplinary Team meeting that's been established at the Mater. She's also a postdoctoral researcher based at QIMR Berghofer, looking into improving diagnostic tools for malaria in resource-limited settings. Welcome, Sumi.
Thank you. Just set my time. I have a tendency to talk too much. So thank you very much, everyone, for having me here tonight. I'm looking forward to this presentation, and it's a topic that I feel very strongly about, and I'm hoping that by the end of my 20 to 30 minutes that you will also be convinced that syphilis is definitely something we still need to be talking about, and we're actually in a position where we really need to have this in the forefront of our minds for all of our patients, regardless of whether they come from a refugee background or not. So a little bit of an outline about what I'm going to speak about. I'll give you a little bit of a flavour for syphilis as it stands in Australia right now. A bit of a syphilis 101 to just bring us back up to speed. And our favourite topic of syphilis diagnosis. I can hear a groan in the audience already. And then a little bit about treatment. And really coming down to the main reason why we're talking about syphilis today, and that's really syphilis in pregnancy and the prevention of congenital syphilis, which is increasingly becoming an issue. So this is some data from the Kirby Institute National Surveillance System, the 2017 report on notification rates for STIs and bloodborne viruses in the last 20 years. And what you can see is the astronomically high rate of chlamydia and a very upwardly trending gonorrhea. And if you look at the light green line at the bottom, that's syphilis. And it's low, but it's going up. And what is clear is that between 2004 and 2016, that rate has actually doubled. When we look at that in a bit more detail, what you can see Australia state and territory-wide is the dashed line at the background, which is an upwards trend across Australia, and some states leading the charge. So Victoria here in the solid blue line, and Queensland in the open lines, and increasingly Western Australia. But if you look at this in context, the axis on this left-hand side, your left, shows you the age standardized rates per 100,000 population for all the other states. But then when you look at the Northern Territory, it actually falls into its axis of its own, because the rates in the Northern Territory are astronomically high and actually still trending upwards. And we'll talk about why in a moment. Where are the syphilis cases coming from? Well, overall, major cities also have a rising trend. If you're in a regional area, that's still trending upwards, but by far and away the largest number of notifications come from remote and very remote areas, and I'll show you why in a moment. So this is the same information in a more graphical format, but just showing you 2014 to 2016 data, showing you that the Northern Territory and far north Queensland, as well as the far north of Western Australia, are carrying the largest burden of syphilis notifications right now. Bearing in mind also that this is age standardized, rates per 100,000 population. So it's partly the numbers are due to the lower population density in those areas, but nevertheless the rates are astronomically high, concerningly high. And this is the health inequality that we're seeing with syphilis playing out in Australia very starkly, is that by far and away, if you are Aboriginal or Torres Strait Islander, your risk of having syphilis is more than 6 times higher than if you're a non-Indigenous background. And part of that comes down to this outbreak, which you'll all be very aware of. There's an epidemic outbreak of syphilis that is multi-jurisdictional, has started in northern Queensland, spread across to Northern Territory, spread across in 2014 through to Western Australia, and then a couple of years ago, cases were started to be seen in South Australia. And the expectation is that this is going to march steadily across the different states over time, unless we can do something about it. So what is syphilis? I apologize if I'm telling you things you already know, but I think it helps to put it into context. So it's a spirochete bacterium, Treponema pallidum. Tricky to diagnose because actually it doesn't culture. We can only see it by dark field microscopy and only seen in an active lesion, and we all know that the primary chancre can come and go without anyone actually realizing it's there, so you miss the opportunity to actually see these beautiful spiral bacteria under the microscope. And so serology actually is the mainstay of diagnosis, and we all love syphilis serology, don't we? We're going to talk about that in a moment. So transmission, it's an STI, it's a sexually transmitted infection, and requires direct contact with the infected lesion. So that it makes sense that the primary chancre is actually the most infectious stage. And wherever direct inoculation occurs, infection can occur and transmission can happen. So it can be the traditionally appreciated areas of perineum, but it can also be lips and oral cavity. And the biggest issue with syphilis, and the thing the reason why we're talking about it, is the issue of transplacental infection and the cause of congenital syphilis. So how do we diagnose syphilis? So syphilis diagnosis, again, rests on serology, and there are two big serological groups of tests. One is the non-treponemal test, which is the rapid plasma reagent, or RPR. And this detects antibodies not against what's called lipoidal antigens, which are usually a breakdown product of damaged cells. And then there are treponemal specific tests. So this is an enzyme immunoassay and also a treponema pallidum particle agglutination or hemagglutinin assay, so TPPA, TPHA. And these are specifically directed against treponema pallidum. So the EIA, as you all be aware, comes up first on our results screen and is actually used as a screening test, and the TPPA and TPHA, or TPHA, are used as confirmatory tests. There's also FTA antibodies that some laboratories also offer. The thing to remember is that treponemal tests stay positive long-term. They can also be falsely positive, which I'll talk to you about. And then, but the RPR changes with treatment and changes with reinfection, and is the marker that we're most interested in terms of following someone's infection or journey of infection. This is that same information presented graphically from a bulletin of the WHO in 2004. So what you can see here, time of infection, and what I was hoping to point out here is that actually the start of your immune response can be delayed by up to 2 to 4 weeks. So this is your IgM curve starting to come up. Roughly 4 weeks later is when your RPR starts to come up. So the key thing being if there's a history of exposure, there is a period of time in which a negative test might be a false negative. So really being aware about the importance of repeat testing for syphilis, particularly if you have the right history or risk factors as part of that profile. As part of that patient's history. And here's the FTA or TPPA antibodies that go positive and remain positive for a long period of time. So this is the diagnostic algorithm, and I'm not going to spend time talking about it except to say that if you do an EIA and the EIA is positive, it automatically triggers an RPR and a TPPA. But again, to point out that you can be EIA negative and TPPA negative, and these might still be in that 2 to 4 week early exposure period. So really important to have repeat testing in the forefront of your mind to make sure that this is truly a negative that you're talking about. And alternatively, EIA positive, RPR positive, TPPA positive. It's really important to clarify previous test results, which I'll come to, previous treatment history, and any new sexual exposures, change in partners that can help you clarify the history. Apart from syphilis serological testing, there's also a role for staging the infection, and this comes down to staging becomes important when we talk about treatment. And staging is actually, I think, what makes syphilis diagnosis much more complicated. So just to try and reframe it, I suppose, one of the first questions to ask is when was the patient's last test, and whether that was a last negative or a positive test puts you into a category of either early or late. So if their last test, if you have a documented last test that's less than 2 years old, by definition you're in an early infection. If it's more than 2 years or unknown, which is often what we see in our refugee or newly arrived refugee population, where we can't be sure when their last test was, they fall into that late staging of infection. The next question comes down to, are they symptomatic or not? If they're symptomatic, so for example, they have a chancre, or they have the classic syphilitic rash that involves the palms and soles of their feet, or they have tertiary syphilis with cutaneous gummas or ascending aortitis or neurosyphilis, then they are categorized as per those symptomatic categories, primary, secondary, or tertiary. But if they are asymptomatic, then they fall into that definition of latent. Then the third part of the history is the sexual and exposure history. So if there's new partner change, multiple partners, or some high-risk feature, that plays into how you stage their disease, and also having a treatment history. And some of this information is already there in the Queensland Syphilis Register. So you just need to give them a call. Syphilis is notifiable in Queensland, so the Queensland Syphilis Register have all this information to hand. If you can document a previous test result within the last 2 years, or a change in serology in the last 2 years, and you're asymptomatic, this is that definition of early latent syphilis. But if you don't know when the test was last done and they are asymptomatic, this by definition is then your late latent syphilis. This is another way of presenting the stages of infection. So early can be divided into primary, secondary, or tertiary. Particularly in the HIV population, they can present with tertiary even though it might be an early diagnosis, or you can be early latent if you're asymptomatic. And then late latent, so asymptomatic by definition, and who knows when the last test was done. So you'll be more familiar with this. So primary disease with chancre, secondary disease with that classic palms and soles infections and oral cavity lesions. Tertiary syphilis, which can present, neurosyphilis can present as cerebral gummas, or ocular syphilis, or sensory neural hearing loss in the context of positive syphilis serology is something to be aware of in terms of an auditory presentation. This picture comes from the New England Journal in 2014 about a cutaneous gamma presenting pre-treatment and post-treatment, and cardiac manifestations of tertiary syphilis are the classic aortitis or an ascending aortic aneurysms. I'm not sure how I'm going for time. I thought we might just flash up a couple of cases just to rethink about syphilis serology. I might just work through a couple of these. So, for example, syphilis EIA positive then automatically triggers an RPR and a TPPA. You repeat the test at 4 weeks' time, and you have a positive but negatives that have remained negative at that 4-week testing. You also have additional history that they were negative 2 years ago and are asymptomatic, have no previous treatment history, and have no new, the formatting's changed here, no sexual history and no new partners, but are currently pregnant. So I think I've lost the bottom bit here. So what we would say for this situation is that the EIA positivity may come about because of the pregnancy, and this is an important thing to bear in mind, particularly in view of your repeat testing being negative. But the differential diagnosis here may be that this is early infection, so really wanting to make sure that we repeated this again, particularly in the setting of pregnancy, which I'll come to why we worry particularly about this. I'm going to skip a couple of these in the interest of time, but perhaps we do this one. I had hoped this would be a nice smaller group that we could talk about cases, but here we go. So syphilis EIA positive, RPR positive at 64, TPPA positive, and you repeat the test and the RPR is going the wrong way, so it's going upwards. You get some further history. They've had a previous treatment 12 months ago, so this by definition then is early, so that categorization. They are currently symptomatic. They have a rash on the palms and soles of their feet, so secondary infection. Although they've tested positive previously, they haven't actually had any treatment history documented, and they have also the additional history of a new partner. So this by definition would be an early syphilis, early secondary syphilis. If we change the numbers around a little bit and change the history a little bit, if the RPI is 16 and you repeat it 4 weeks later and it's gone up to 64, but you have a treatment history that says, well, they were previously tested 12 months ago, so this is still early, they're still symptomatic, this is secondary, but they were treated for syphilis, and their titer at the time of treatment was 128. And there's a very clearly documented treatment history for a primary syphilis, but they have new additional sexual history and a new partner. So how we would be interpreting this is their previous 128 has come down to 16 in the context of treatment, but in the setting of a new exposure and a rising RPR, this is most likely a reinfection. So we can talk about these sorts of things for a long time, but the reason why it's important to interpret syphilis serology in the context of the stage of infection is that the treatment recommendations are different, whether you classify them as early, late latent, or tertiary. So early being the single dose in each buttock once, or late latent, where it's the treatment once a week for 3 consecutive weeks, or tertiary, where it requires intravenous treatment for a period of 15 days. And the follow-up, regardless, is every 3 months, so 3, 6, and 12 months. And a definition of treatment success is a 4-fold drop in titer during that course of treatment. Bearing in mind that in the pregnant population, sometimes we don't achieve this during the course of their pregnancy, but it's that trend in RPR, the downward trend, that's most important. So let's get to the real reason why we're talking about syphilis now. And the reason is this. I didn't show you this before, but when we look at our syphilis notification rates by sex, what we can see is that, yes, the rates are going up across Australia. The rates are increasing are continuing to increase in males. But worryingly, in the last 4 years, the rates in women are also starting to go up. And if we drill this down a little bit more, notification by year, by age group, what we can see is that these notifications are coming predominantly from our women of childbearing age, ranging from 15 through to 39. And you can see that these notification rates are very steep and trending up very, very, very fast. Pointing out here, so the grey bar is the 25 to 29, the open bar is 15 to 19, and 20 to 24. So if this trend continues, what we are inevitably going to get is increasing syphilis in pregnancy, during pregnancy screening, and the risk then is congenital syphilis, transplacental transmission, and congenital syphilis. And this is why we really need to be talking about this right now. And are we immune in Greater Brisbane? Is this just a regional Australia issue? And the answer is no. What you can see here is that right in the middle of Brisbane and on the Gold Coast, we can see that we are in a high notification area, and it is expected that based on numbers in the last 2 years, which have seen a trebling of notifications in women of childbearing age, that this trend is going to continue. So we're going to see women with positive syphilis serology in pregnancy in all of our clinical practice. And this is what we want to try and avoid. These numbers are not acceptable. This is congenital syphilis rates per 100,000 live births in the last 10 years. And you can see that the rates among Aboriginal Torres Strait Islander babies is much, much higher. But this number is also going up across Australia. And if that trend in positivity among pregnant women continues to grow up, what we don't want to see is that this starts to go up too. So as I said, the reason why we're still talking about it is because syphilis is becoming an increasing issue in pregnancy. The international data would suggest that there's approximately 1 million pregnant women with positive syphilis serology, with infectious syphilis, so that early syphilis. And that this translates to syphilis being the second biggest cause of stillbirth at a global level. And locally, what we're seeing is that in the last 2 years alone in southeast Queensland, so this is there's been a 3-fold increase in notifications in women of childbearing age, and particularly in pregnancy. And the demographics of the cases in the southeast Queensland corner are very different to the far north Queensland. It is in non-Indigenous patients. It's often in marginalised women who are very vulnerable, very socially isolated, and very difficult to engage in healthcare. But it also spreads across the socio-economic divide, so it's not separated by that. And in the context of this rising rate in the last 12 months in Brisbane alone, there have been 2 cases of congenital syphilis. The congenital bit has fallen off there. And so congenital syphilis. So how do we make the diagnosis? And actually, it's pretty difficult to make the diagnosis, partly because it can present very, very non-specifically. Often the babies can be born normal at birth and develop symptoms later, right up to about 2 years before some of the symptoms may manifest. By that stage, the maternal syphilis history is long forgotten or not considered. And the presentation is really generalized. So jaundice, anemia, generalized lymphadenopathy, hepatosplenomegaly, and some of these trigger investigations down the malignancy line initially. So skin rashes, but there are some fairly classic features, so condyloma lata, osteochondritis and periostitis in babies, and mucosal ulceration and heavy nasal mucosal discharge is one of the features. But as you can imagine, these are very non-specific features. The diagnosis also rests both on a clinical diagnosis as well as abnormal serology, where the neonate serology RPR is a fourfold higher titer than their mothers, and a positive syphilis IgM, which is done at birth ideally. And these babies invariably need pediatric infectious diseases input. The problem is not just the disease, and it's the impact of the disease. So it has a significant neurological impact, both acutely and long term. So these are ongoing healthcare costs, but also social costs to families and increasing healthcare costs into the future. And this issue of congenital syphilis is not just something that's becoming an issue in Australia. So the US is also raising alarm bells around the number of congenital syphilis cases that they're seeing. 2017 data for the US suggested 900 cases of congenital syphilis in the US in that year. We're not talking about a small problem. And so the rest of my talk is going to be about syphilis and pregnancy. And there are some differences in thinking about syphilis and pregnancy, and this is regardless of whether this is in a refugee population or a newly arrived migrant population or not. So all women, as you know, are offered serological screening at the time of pregnancy or ideally in the first trimester. But this is the key thing, is that women of higher risk and need to have screening done at multiple times during their pregnancy, ideally again in the second trimester, ideally again late in the second trimester, and ideally that 4 to 6 weeks before delivery, because there's opportunities at each of these points to intervene and prevent that onward transmission and onward risk of congenital transplacental transmission. And to go back to the two cases that I discussed earlier, both of those had mothers that had been screened early in pregnancy and were negative at their first screening, but had subsequently been exposed to syphilis during their pregnancy, but never had the opportunity to be screened. Any woman who has, these are guidelines, these are Australian and international guidelines, that any woman who's had a fetal death after 20 weeks should have syphilis serology done, and anyone who's never had syphilis serology during the pregnancy should also be screened. You're not meant to be able to read the slide, but just for me to be able to give you the opportunity to, or to let you know that there are some new Queensland clinical guidelines being released imminently around providing some increasing guidelines around managing syphilis in pregnancy. And what I'm trying to highlight in this document is that assessing pregnant women about their syphilis is actually really complicated and very time-consuming, and has a few key issues that we need to focus on, which I'll come back to. But taking an allergy history, looking back at their pregnancy history, because this might be the first opportunity to discuss whether there had been an exposure in the past and potentially identify babies that have already been born that have for whom this is not flagged yet, but who might still be at that risk period for developing signs and symptoms of congenital syphilis. And then the importance, it's fallen off the bottom of my slide there, but the importance of ongoing serological follow-up during their pregnancy. And this is something that's specific to syphilis diagnosed in pregnancy. So these are the additional considerations for when you make a diagnosis of syphilis in pregnancy. So most women will have a morphology scan at 20 weeks. If the diagnosis has come about prior to the 20-week scan, the 20-week scan can be used to look for any evidence of congenital syphilis, ultrasound evidence of congenital syphilis. But bearing in mind that a negative ultrasound does not mean that the baby might not still have congenital syphilis. They just may not have florid manifestations of that are detectable ultrasonographically. In terms of the risk of transmission, developing primary and secondary infection carries the highest risk of transmission during pregnancy. And so you can imagine that someone who's been negative in their early pregnancy screening, who has then had a high-risk exposure, is then at much higher risk of transmitting to their baby. Treatment later in pregnancy is associated with risk of transmission, and treatment that's completed less than 4 weeks prior to delivery is associated with a higher risk of transmission. Hence that 34 to 36 week repeat screening opportunity to try and intervene and get penicillin into them. The other issue with pregnancy and syphilis management is that you only have one treatment option, and that's penicillin. So if someone has a penicillin allergy, we're looking at trying to desensitize them to provide them with the appropriate treatment, because doxycycline is contraindicated in pregnancy, and there have been documented failures of ceftriaxone and azithromycin, which are other second-line options for non-pregnant patients, but clearly not suitable for if you have a pregnant patient with syphilis. The issue of Jarisch-Herxheimer reaction, so this is the immunological reaction associated with treating syphilis. This occurs at the same rate, whether you're pregnant or not, but has bigger implications if you're treating a pregnant woman, because it can induce premature labor. So if you're treating particularly a woman later in their trimesters, later in pregnancy, there is a risk of a higher risk, or believed to be a higher risk of JH reactions, and then that may trigger early labor. So that needs to be considered and treated, managed carefully. This is what's key actually in syphilis management in pregnancy is partner testing, because this is the key issue for breaking the cycle of reinfection and transmission during pregnancy. Because we might have screened the woman early in pregnancy, but if the partner remains untreated, there's a risk of transmission. And like I said, if the woman gets syphilis and it's primary or secondary, her transmission risk is enormously high. So the recommendation is for a partner of a syphilis contact to be tested, because we need to know if they're RPR positive in terms of their follow-up, but to be treated on site so that you have the opportunity to intervene regardless of their staging, which you can spend time working out later. And there's some guidelines about how to risk stratify that primary, secondary, and latent syphilis. And then this is the other issue of managing syphilis in pregnancy, is that women who are diagnosed in pregnancy need monthly serological follow-up. And for that very same reason is that we want to see their RPR coming down as a confirmation of treatment success, but we also want to detect any RPRs that are going the wrong way and trending upwards because of a reinfection, so that you have an opportunity to intervene. Because it's all about looking for opportunities to intervene and prevent that congenital syphilis case. Oh, I'm over time. I'll be quick. So at delivery, there's a couple of extra things to be aware of. Maternal testing needs to happen, and this needs to be in the forefront of our minds, because placenta needs to be sent fresh for PCR and for histology to look for any evidence of treponema pallidum, and mother needs to have serology testing done, and as does the baby. And this must be done, the baby's testing must be done on the baby's blood and not on the cord blood, and that becomes really important. And obviously the referral of the baby to pediatric services for follow-up. So as I hope is clear, is that syphilis in pregnancy, not only is it important, but it's complicated. And and because of these increasing numbers and our concern about increasing rates of positivity in pregnancy, what we have tried to do at the Mater is set up a syphilis in pregnancy service, to which any woman who is pregnant, who has positive syphilis serology, can be referred to or can be discussed with us with regards to advice on management. A referral generated to this service will be seen urgently, and treatment initiated at the time of presentation to our clinics. And What this service is also offering is a multidisciplinary team-based approach where we already have an MDT that discusses patients with infections in pregnancy that involves an adult infectious diseases physician, a pediatric infectious diseases physician from LCCH, obstetricians, gynecologists, midwives, neonatologists, MRCCC from a refugee point of view, and Indigenous health as is relevant to the particular patient being discussed. And the idea would be a comprehensive plan for testing, follow-up, treatment, any additional imaging that needs to be done to be fed back to the treating primary care physician, but also to their treating antenatal team to be able to have a service that bridges that gap that bridges both primary care and tertiary care. And we would really welcome the opportunity to work with any of you, all of you, happy to be contacted with regards to any of these complicated patients that you're seeing, with the idea that really our focus is trying to prevent that onward transmission and preventing congenital syphilis. So in summary, syphilis rates are going in the wrong direction, trending upwards. It's a very treatable condition and the treatment is cheap compared to the cost of particularly, say, for example, congenital syphilis and the consequences in the long term. And treatment by vast majority of the time prevents complications. And the reason why we're still talking about syphilis, and we need to keep talking about it, is that there's a rising rate of syphilis in reproductive age females with an increasing risk of transplacental transmission and therefore manifestations of congenital syphilis. And we know that the assessment and managing of syphilis in pregnancy is really complex, and we'd like to be able to help with that, but our ultimate goal needs to be the prevention of congenital syphilis. And with that, I'll stop and take any questions. I'm sorry, I ran over time. That's all right.
So do we have any, Vicky's here with the microphone, if anybody has a question for Sumi? You've answered them all already, I think.
Completely good. Always happy to be contacted if you have any questions or need to discuss something.
Thank you very much, Sumi. And thank you to our other speakers tonight as well, Dr. Coulter and Dr. Griffin. I think we have time for sort of general questions if anybody does have any other questions that they wanted to ask of the speakers. Good. Well, in that case, thank you to all of you for coming to... Oh, no, sorry, we've got a question. Is this a...
Check. This is one that came in from the Zoom meeting. What are the detail of the syphilis service? That was word for word, sorry.
So is that, what are the... How do you get in touch with the syphilis in pregnancy service?
It says... She just said yes.
Yes.
So that's so two ways. One is through the Queensland Syphilis Register. So anyone that the Queensland Syphilis Register that rings you about who might be pregnant, whom you wish to discuss any further, they'll be able to direct you to us. It's also a standard MARTA online referral to the Infectious Diseases Service, and we will they're looked at every day and we prioritise them. So if there's someone with positive syphilis serology and they're pregnant, they will be prioritised as an urgent review in our clinic. So it's just MARTA, standard MARTA referral process, or through Queensland Syphilis Service. Hope that answers.
Thank you. Are there any more online questions? Very welcome. Okay, so in which case, thank you to everybody for coming. I think you should have your evaluation form. Oh no, another question.
This is a comment for the Paul. Some years ago, a physician actually pointed out that if you weren't sure whether someone was going through an influenza type of or a viral illness, or whether they're actually having an acute malarial episode, he said ask for sore throat, and apparently sore throat never occurs in malaria. Would you rely on that criteria?
I mean, I think the key is that there's nothing specific in the history that can exclude malaria, unfortunately. So the presence of a sore throat or carousal symptoms would certainly point you more towards a viral cause, but it's not specific enough to not do the test, basically. So I think if someone has a fever and they've been somewhere with malaria, it's still important to do the test.
Does sore throat occur in malaria?
It wouldn't be a common symptom. But I guess, particularly if someone's recently travelled, they may have intercurrent viral illness, and again, you wouldn't want to assume that everything is due to that and not test for the malaria, because the consequences of missing it are so significant, and the test is so readily available that I would still do the test, yeah.
This is one more question about malaria. I don't know if you covered this or not, but is malaria also common in Papua New Guinea?
Okay, so it looks like everybody is very busy filling out their evaluation forms, which is great. And Andrew and Elham are hanging out by the door there to receive your evaluation forms and give you your parking tickets so that you can get out tonight. So thank you all for coming. I hope it's been interesting for you and useful, and we hope to see you all again at the next one. Thank you.